The biliary system. This session covers gallbladder and ductal anatomy, focusing on diagnostic criteria required for the ARDMS abdomen registry. The gallbladder is an intraperitoneal organ located in the gallbladder fossa. The primary sonographic landmark is the main lobar fissure, which connects the gallbladder neck to the right portal vein. Anatomically, the wall consists of four layers: outer serosal, subserose, muscular, and inner epithelial. Vascular supply is provided by the cystic artery, a branch of right hepatic artery. Functionally, bile release is triggered by cholecystokinase. Accuracy in measurement is vital for the registry. The gallbladder wall should not exceed 3 millimeters when measured in anterior-posterior dimension. For the ducts, normal common hepatic duct is 4 millimeters or less, while the CBD should generally be 6 millimeters or less. Note that CBD may increase by 1 millimeter per decade after age 60 or post-cholecystectomy. Recognize these variants to avoid false positive pathology. Phrygian cap, the most common variant, a fold of a fundus over the body. Junctional fold, a fold at the neck and the body junction. Hartmann pouch, a posterior outpouching at the neck. Biliary atresia, a critical pediatric diagnosis involving the absence of or obliteration of the extrahepatic biliary tree. The biliary tree begins with the right and left hepatic ducts, which join to form the common hepatic duct. Once the cystic duct form the gallbladder joints, it becomes the common bile duct. The CBD then travels posterior to the first part of the duodenum to meet the pancreatic duct and the ampulla of water. Identify these diagnostic signs. Mickey Mouse sign, the transfer view of the porta hepatis. The portal vein is the face, hepatic artery is the left ear, and the CBD is the right ear. Shotgun or parallel channel sign indicates ductal dilation where the duct matches or exceeds the diameter of adjacent portal vein. Double arch or vest sign indicates gallbladder packed with stones. Visualize the wall, echo of the stone, and the shadow. This orientation at the porta hepatis is high yield. The main portal vein is posterior, CBD anterolateral, and the proper hepatic artery is anteromedial. The ductal diameter are dynamic. In normal adults is between 3 to 6 millimeter. Post cholecystectomy is the CBD can dilate up to 10 millimeters as it acts as a reservoir. Always factor in patient's age and surgical history before documenting the pathology. Risk factors follow the 5 Fs: fat, female, fertile, 40, and fair. Sonographically, look for mobile echogenic foci with posterior shadowing. If the gallbladder is full of stones, document the West sign to confirm the organ is present but obstructed. There is several types of cholecystitis. Acute, usually due to impacted stones at the neck or cystic duct. Critical findings include a positive Murphy sign and the wall thickening. A calculus is inflammation without the stones, typically seen in critically ill or post-surgical patients. Emphysematose, a surgical emergency involving gas-forming bacteria. Look for dirty shadowing or rain-down artifacts. Adenomyomatosis, hyperplasia of the wall causing Rokitansky-Aschoff sinuses. Look for pathognomic common tail artifact. Cholesterolosis is a strawberry gallbladder. Small, non-shadowing, non-mobile polyps. Gallbladder carcinoma. Suspect if a polyp mass exceeds 2 millimeters or if the gallbladder is replaced by a solid mass. Klatskin tumor. A specific cholangiocarcinoma located at the junction of the right and left hepatic ducts. Final review points. Bile release is controlled by cholecystokinase. The upper limit for the wall thickness is 3 millimeters. Spiral valves of Heister are located in a cystic duct. A palpable non-tender gallbladder associated with jaundice is Courvoisier gallbladder. It's typically indicating a distal obstruction, such as pancreatic head mass.